Good evening, everyone from cold Newark, New Jersey. Thank you for joining me in number 7 of an 8-part series, The Essentials in Oral Health, exploring topics in preventive dentistry and periodontology. This is sponsored by Johnson & Johnson. This series is offered to you as members of the Next DBS user community. My name is Dr. Kenneth Markowitz. I'll be your guest speaker for this session. I am on the faculty of Rutgers School of Dental Medicine. I have studied caries and other tooth-related issues throughout my career in dentistry. As some of you may have run into me from other webcasts, I am currently conducting studies of caries in adolescents, longitudinal studies, and working on evaluation of various caries detector devices that dentists use in their offices. I'm a member of the oral biology department at Rutgers. I teach course materials in caries, dental pain, dental pharmacology, anatomy. I also practice dentistry at the faculty practice at Rutgers. Our presentation tonight will be entitled Clinical Application of Disease Detection and Management for Preventive Dentistry. And I'm looking forward to sharing some great information with you. A couple of things first. This webinar will run approximately 45 minutes. You can type in questions using the tool at the bottom of your screen. Usually I try to answer them during the presentation so that we can all share the information. And so I believe if there's no other further business, then let's proceed. Okay, so title is Clinical Application of Disease Detection and Management for Preventive Dentistry. Okay, so, why do we do this? That's a good question. Why is the profession evolving in this direction? It's really quite a bit different than when I was a child going to the dentist, or even when I was in dental school. Why do we do preventive dentistry? See here a picture of Einstein doing, I think, an imitation of Gene Simmons from KISS with his tongue hanging out. The only thing that could interfere really with learning is education. There's a difference. Learning is lifelong. I love learning. I love reading things. I love talking to other people in the profession and in other areas. You really get a lot out of it. Insanity is doing the same thing over and over again and expecting different results. I have really dealt with this firsthand. I used to be, when I was a young dentist, worked in a health center in New York City. And, you'd fix up a person's tooth, you do fillings, and, oh, boy, get them again, and everything is falling apart. There's plaque all over the teeth. There's new caries. Why isn't the excellent treatment you're doing having an impact? It's because there's something missing. There's more to dentistry than just really the fixing things aspect. So our learning objectives in discussing this is to understand prevention, give examples of prevention, examine facets and options in preventive dentistry. What is the benefit? Really, what is the benefit not only to our patients, but to our practices, our future practices? How is a preventive practice a better practice and actually a more prosperous practice than a practice that just is sort of behind the 8 ball and trying to treat these diseases? What are some ways that we can help patients understanding their health and improving their health themselves? And what is evidence-based dentistry? What's really the gold standard for knowing if what we're doing is the right thing? Is it opinion? Is it our own inclination? Or are we able to actually gather together the combined experience of a lot of other doctors and really get a good handle on sort of what is success and what isn't, what develop really best practices? Okay, so continued emphasis on preventive dentistry. We're all trained. You have preclinic. I teach preclinic. We all teach how to do very good dental procedures, how to do restorations, how to do crowns, and so forth. And we work in operatories. We don't work in exam rooms. We basically are very focused on fixing things, being hands-on and fixing things, trying to remove diseased tissue, preserve healthy tissue. We need to develop more of a focus on really changing the direction the patient takes when they're not in our chair. That's the thing. We only have contact with patients a couple of hours, in a whole year. It's what goes on the rest of the time that really matters. If you look very carefully at this slide, it looks like an operating room, the dental equipment. You look closely, it's actually a veterinary dental operatory. Because if you look very closely at the screen, that's an x-ray actually of animal teeth. It looks like dog teeth. Actually, it looks like the teeth of a very young dog with very wide pulp chambers. We're dealing with people that can make an impact in their own health. Okay, so sometimes we don't really act that way. We act like the important thing is what we do to fix people up, and what happens at other times is not really important. So that's really a very good opportunity we have to explore these issues together. Types of prevention. There are various stages of disease. There are also stages of prevention. Primary prevention could be considered the prevention of even the earliest manifestation of disease, whereas secondary prevention is basically a minimally invasive approach to repairing or stopping further damage once a disease occurs. And then tertiary is really preventing or preserving the patient's health by treating diseases at more advanced stages. Okay, so prevention really applies to all stages of the disease process. Okay, so conceivably, you have a person, you want to prevent caries. You want to essentially halt caries at the very earliest stages. Now, that really entitles treatments other than restoration. And tertiary prevention could be minimally invasive, as little as possible surgical intervention in order to actually then preserve the tooth structure and preserve the overall dentition of the individual. Okay, so various stages of prevention are very important. Okay, the benefits of a preventive approach is, well, obviously for the people that it works for, they will have improved oral health and improved quality of life. They will have less health care expenditure, so there'll be less work absenteeism from work, from school. There'll be less incidents of other problems associated with their teeth. And this is important because caries, a lot of people are experiencing reductions in caries, but overall there's plenty of caries out there. The incidence is rising. People are keeping their teeth longer, so the root surfaces, which are normally not exposed in a young person, as a person gets a little bit of gumline recession, periodontal disease, their root surfaces are susceptible to caries. So there's still plenty of decayed, missing, and filled teeth in the population. I studied this in Newark, New Jersey school children. A very small percent, what was it? I think something like 70% of all children had unfilled cavities in their teeth. Okay, so they needed restorative treatment. And this results in problems for individuals. It could result in emergency room treatments. It could result in pain, infection, sometimes even dangerous infections. So this is a global problem, and by just approaching it from the sort of restorative standpoint without understanding the preventive strategies, we are actually fitting the definition of insanity. We're doing the same thing over and over again. Prevention is something for life. In children, caries is known to be a transmissible disease, so there could be possibly ways that we can interrupt the transmission between mother and child. I think in my first webinar, we discussed that a little bit, and there's plenty of literature on that. If you look up transmission of or vertical transmission of caries, you'll find quite a lot of studies. Adolescence is a time when caries is a problem because children eat a lot of candy, and they don't brush their teeth as well as they should. So people who even avoided caries in early childhood can get caries in later childhood, in adolescence. Adulthood and in old age. The entire nature of old age has changed in our society. People are working longer, they're living longer, they're enjoying health longer. When dental care in older individuals, it has undergone a revolution. When I was a child, when I was like 5 or 6 and I visited Grandma, you had to watch out what glass you were drinking from, that you didn't actually drink from a glass that contained Grandma's teeth. Today, older people are getting implants, they're getting more complex preservative treatments that are really designed to preserve their natural dentition. Even with excellent prevention, though, there is a need for dental treatment because certain problems that the teeth and the rest of the human body face are really matters of mechanical wear, big things sort of like the human being versus the clock. So teeth will wear, restorations will fracture, will chip. So older people need dental care even if they enjoy a lifetime of good dental care. So there's a need for prevention for things like wear and erosion of teeth as well. Okay, globally, think of it, there are many things that we can do. We can adopt caries management by risk assessment, what's called CAMBRA. There is an organization that Restorative and other dental faculty belong to where we have what's called a CAMBRA program, and we design CAMBRA protocols for our individual schools. So I help design basically a caries risk management assessment system for our school, and many schools have similar systems. So you have a patient, you treatment plan a patient, you have to understand the caries risk. And it could be arranged so that you may not even be able to do complex dental treatment unless they know that the caries risk is managed. Let's talk about that for 1 second. Why does that make sense? Why does it make sense to possibly not do extensive crown and bridge on a patient who doesn't have good control of their caries risk factors? Because you're not basically practicing dentistry in a reproducible and reliable fashion. Okay, if you're doing treatment and the teeth are breaking down, shortly after you do the treatment, it makes us all look bad. Okay, so a preventive-oriented practice is likely to be a successful practice because patients will have respect for your skill, for your knowledge, and your concern for them. Other early interventions, minimal approaches, fluorides, varnishes, sealants, early detection of other dental diseases and systemic conditions in a setting where there's ongoing surveillance, patient education, and outreach to the community. So basically we treat the patient, we treat the teeth, we also, in a sense, treat all of society and the global population in this fashion. Caries management by risk assessment. This has become really very, very important as being recognized as a thing that dentists and dental schools and so forth should do. What are some of the caries? I'll answer that question in a second. Excellent question. What are some of the ways that we can look at caries risk? Well, I did a study which showed that previous caries is #1 risk factor. A person has had caries, they are likely to have caries, or they're at risk for having caries in the future. Maternal history is important since The bacteria that cause caries are transmitted from mother or other primary caregiver to infant, okay, once the teeth erupt. Diet is very important. If you don't feed the bacteria, it will not generate acid. It's really quite as simple as that. You know, we eat food and so do bacteria. Bacteria that causes caries generate acid. Clinical examination, documenting the caries lesions, doing various tests, and then, you know, basically recording all of this information and using this information to follow the patient. This is all part of a caries formula. Okay, question here. Seems like there are a lot of risk assessment tools. Is a unified approach on the horizon? What I think is going to happen is that various aspects of caries risk assessment programs will be tested, and basically winners and losers will emerge. And as time goes on, it's probably likely that caries risk assessment methods will get simpler, quicker, easier to use, and actually more effective in predicting risk. Okay, so eventually what needs to be done are clinical studies where you really look at the capacity of the risk factor to be associated with a higher incidence of disease. Okay, you know, we talk a lot about statistical and research methods that we can do that. Okay, so as time goes on, the important factors will emerge and the less important factors will possibly take second stage. Okay. Good example of this is diagnostic tests other than x-rays. Let's say saliva flow or tests of what bacteria are present in the mouth. Those may have a role, okay, but those might be difficult to do in practice, whereas things like dietary history, caries history in terms of how many lesions were in the past, those are probably likely to be the more important things as we move forward. Okay, early intervention, you know, basically primary types of prevention. Periodontal disease treatment in terms of training the patient to clean their own teeth, clean teeth for the patient. Fluoride treatments, fluoride prescriptions. There is a role of antimicrobials. Once again, you know, it's a little bit hard to assess. Restorations in areas where there are active lesions, where the lesion is likely to progress without a restoration, and evaluation of previous rate of restorations and patient education. Okay, restorative surgical management of caries is an area where there has been a tremendous amount of soul searching, a tremendous amount of change, some of which has been adapted by United States dental schools. There are other regards in which United States dental schools are possibly lagging behind institutions in other countries. Basically, the trend is a minimal approach. Okay, if basically there is a caries lesion where the lesion is likely to get worse without operative restoration, basically the name of the game appears to be to really use a light touch. Okay, to basically do good peripheral excavation, avoid undermining and weakening the tooth, and avoid pulp exposure unless it's really necessary. So preserve as much tooth structure as possible and really try to avoid undermining and pulp exposure. So actually, the first molar in the upper picture there is a very good example. Notice that the transverse ridges of that upper molar are preserved, as are the marginal ridges of both teeth. They have basically 4 marginal ridges that are nice and intact, preserved, okay? The best matrix band in the whole world is intact human enamel. So we should try to avoid dropping boxes, etc., unless we really have to. Okay, so minimal invasion, preserving tooth structure using restorative materials that will basically reinforce the tooth rather than weaken the tooth. These are all really the trends in restorative care. Part and parcel with that, though, is an excellent marginal seal and excellent peripheral excavation, making sure the margins of the restoration are caries-free is an important component of actually minimally invasive management of caries. So conservative treatment, try to save as much tooth structure. An interesting issue that's come up in the literature is, possibly not even is less aggressive treatment, surgical treatment of caries, possibly not excavating caries that is right over the pulp, if that would jeopardize a pulp exposure. So there are a couple of very good studies studied by Maltz et al., a couple of new studies that show that a conservative approach to caries treatment, at least over intermediate time frames, 2 or 3 years, there aren't that many long-term studies, but at least over relatively intermediate 2, 3 or so year time frames, appears to be very, very successful. So strive to save tooth structure. There is not evidence that really aggressive treatment gives better long-term results. There is an option of removing carious material, placing an interim restorative material, and then allowing a little bit of healing on the inside of the tooth, and then completing the excavation on a subsequent visit. That's called stepwise approach. That's an option. And there's really no good evidence that aggressive treatment gives better results. Fluoride is a mainstay. Fluoride, however, is not a panacea. Fluoride will not make teeth caries-proof. It's not like a vaccine for caries. So fluoride will essentially make the tooth structure resistant to dissolution. However, the tooth structure will still dissolve if the plaque is generating acid. It'll slow it down and it'll decrease it. So fluoride should not be considered something that you just hand patients and expect the caries problem to go away. It's not like giving prescription for a sore throat or something like that. It doesn't work that way. It's great as a adjunct, as part of a caries control program, including diet and oral hygiene. By itself, if all of the acid attack, if there's still a lot of sugar ingestion, if there's poor saliva flow, things of that nature, fluoride isn't really going to tilt the balance. It's just a sort of adjunct. Okay, does a child's caries risk determine the manner in which you talk to the parent's guardian? How does the advice you give them change? Yes, I think it does. If a child has high caries risk, you're going to advise, you're really going to ask the parents to really look into the diet, the oral hygiene. You're going to suggest healing for the child, So I did a study which showed that children that have a high caries incidence are more likely to get occlusal caries on their initially unrestored, uncarious occlusal surfaces on their erupted molars. So if a person has high risk, the child has high risk, they're more likely to need sealants, they're more likely to benefit from sealants. So their caries risk assessment is very important in determining the risk management treatment moving forward. So that's a very important factor. Okay, very, very, very good question. Okay, so fluoride is available in a number of forms. Fluoridated dental products, water, varnishes that are professionally applied, topical gels, etc. So there are a lot of ways to apply fluoride. Water fluoridation is important, even given that we have other sources of fluoride. Okay, so water fluoridation essentially is a minimum level of prevention that everybody can get, even if they don't go to the dentist, even if they don't brush their teeth. So it's important as sort of like a minimum sort of safety net under the population in terms of prevention. Sealants and varnishes. Study after study has shown the effectiveness of sealants. Those are resin-based restorative material that's placed over the occlusal surfaces of teeth. Varnishes are not quite as permanent as sealants. They last for a day or so, but they can carry very high fluoride. So fluoride varnish can transfer quite a bit of fluoride to the tooth surface. So sealants for occlusal surfaces are very effective. For other surfaces, like smooth surfaces, varnishes are quite good. But sealants are really the best and very, very uniquely effective to prevent occlusal caries. Antimicrobials are helpful. Many studies have shown that they can sort of extend the benefit of brushing and flossing. Okay, so Listerine, other mouthwashes can basically penetrate the plaque and kill residual organisms that are left behind after a person brushes and flosses. Okay, so one study that we did on Listerine showed that in patients that had periodontal pockets that were, starting to be indicative of periodontal disease. So I don't know how many of you really studied perio in detail, but when you start seeing a person with a 5, 6, 7 millimeter pocket, that's considered having periodontal disease. So in patients that had 5 to 7 millimeter pockets that had the dangerous periodontal pathogens in them. So these pockets, we tested them and we found that they had some of the anaerobic organisms that are known to cause periodontal disease. So people that had this sort of moderate periodontal disease, Listerine twice a day rinsing for 2 weeks significantly reduced the levels of these periodontal pathogens in these people's pockets. Now, whether that indicates that it could cure periodontal disease would probably be overstating it. But it does indicate that antimicrobial rinses, like fluoride, also are a good adjuvant in our treatment. Okay, so we wouldn't just rely on a mouthwash to basically cure periodontal disease. That's a little bit more complicated. But a mouthwash could conceivably be a useful additive effect in our other treatments of gum disease. How do we detect oral diseases early? So part of, I guess, what you call secondary prevention is really minimizing the damage once it's really just barely getting started. Okay, so early detection of oral disease, we have a number of ways of doing that for various diseases, oral infections, orthodontic problems, cancer, early erosive lesions, basically dealing with health consequences of oral piercings, etc. Oral cancer screening is, of all the things dentists do, this has got to be one of the most important. Quick, simple. Most patients might not even be aware that you're doing it while you're doing it, but you can save a life. Okay. Any of us who work in situations where we see a lot of older adults, etc., will eventually see oral cancer, possibly multiple times in their career. I know I have. Smoking is a primary risk factor, as is alcohol consumption. However, infection with human papillomavirus is also an independent risk factor for oral cancer. So many populations, young, healthy individuals who in the past would not be thought of as being at risk for oral cancer are in fact being diagnosed with oral cancer because of these viral infections that could also be a risk factor in oral cancer. Okay, the oral cavity is an important sign of a person's lifestyle and systemic health. Acid erosion, reflux. I think in one of the other webinars we talked about lingual surface erosion, especially in the upper teeth, could possibly be a sign of a fatal, of a serious eating disorder. Person forcing themselves to vomit. Drug abuse also takes a terrible toll on people's teeth. It says on the slide here that dental erosion from amphetamines, well, I think it's more so that the erosive effect of the amphetamine, the fact that people who are drug abusers have a poor diet and don't brush their teeth, possibly more than the direct effect on the drug. It's a combination of risk factors that could really be extremely damaging to a person's teeth. And I believe in most of our dental clinics, we see a lot of drug-dependent or formerly drug-dependent individuals who have dental signs of drug abuse. And of course, the big daddy of all oral systemic conditions is radiation treatment, which damages the saliva glands, causing a very severe dry mouth, which predisposes individuals to horrible caries. So all of the good things that saliva does is taken away, and the teeth are susceptible to extremely serious caries. So people who are having radiation treatment, they're the ones that really need our help. Okay, we really have to do a great deal of dietary manipulation, oral hygiene improvement, as well as what. It's not just handing them fluoride, okay, to try to control this very devastating problem that they develop. Okay, so an important part of caries risk management strategies is follow-up and documentation. Most of our schools have Axiom, have different sort of methods of recording and hanging on to information. And this is really very, very important, because this way we can basically, we can essentially follow patients and also get information to see whether their risk management strategy is working. Okay, so in Axiom we have ways of reporting two-surface condition, and we can follow it over time. This is really important in understanding the impact of caries risk assessment. Well, patients have responsibility too. They have to basically wash and rinse, and there are different methods of doing this. There are different interviewing styles that you can take. There are different methods of speaking to patients in order to really make it seem like they're the ones that are initiating the change. People don't like to be lectured. They don't like to be bossed around, okay? Certain things that we can use to help us is the fact that nobody wants pain, nobody likes needles, and I have news for you, nobody likes to have their teeth drilled, okay? So by getting people to avoid this, then we can work with them. Now, many people in our population have the consequences of past dental conditions to deal with. So practicing preventive dentistry doesn't mean that we're all going to stop treating patients. It means that we're going to concentrate on, and the patient's going to be able to concentrate on, really the important things, the things that are worth doing. They can improve their smile. They can address their aesthetics. They can get missing teeth replaced without really being too concerned about needing a DO amalgam on number 15. They can have that implant. They can have veneers. They can focus their dental attention and resources on the things that are really worthwhile doing by practicing prevention. So prevention doesn't mean less dentistry. It means targeted, focused, predictable dentistry. Okay, that's why I like it. That's why I would like to really transfer to you students basically my enthusiasm for preventive dentistry. It doesn't mean that we're going to just all become professors. It means that we're going to practice, but we're going to practice a higher quality and better quantity of dentistry than what people that were just kind of chasing around patients' problems in the past did. So patient education is really the cornerstone here, really powerful, okay? It's effective in all age groups, okay? There are a number of modalities that we can use in patient education, okay? One-on-one with staff, hygienists, posters, videos, handouts. I think it's basically standard practice that when patients come in for recalls or for first visit, you give them essentially your recommended oral health care products. Actually, one thing that I would try to put in a plug for is to try to encourage patients to attempt to use, this is something you're not going to hear every day, unwaxed floss. Okay, I find that wax floss, glide, a lot of the things that we give patients as free samples are not very effective at cleaning teeth because they're, to put it simply, too slippery, okay, to really kind of grip onto surfaces and clean well. So I would say trying to use unwaxed floss unless the patient has extensive restoration and very tight contact. So basically, this is something we have to do with every patient every time. Because, another thing that's important is when you examine patients, when you are doing treatment, you see things that the patients themselves don't see. When I get my teeth cleaned a couple of times a year, the hygienist tells me areas that I don't do as good a job as I think I should. I think I clean my teeth very well. So it's very important to have this sort of ongoing dialogue with people to keep them interested and also ultimately keep them enjoying coming to the dentist and coming back. This is something that really is very important across the board in our society. So untreated oral disease is a huge burden in society. It affects quality of life, work productivity, general healthiness. It adds healthcare costs, adds stress to the entire healthcare team. So this is something we should really be involved in. The dean of our school records has been very active in trying to really get a handle on a big problem today, which is people getting emergencies and then going to the emergency room to have dental emergencies treated, things that should be very easily taken care of in a dental office setting. What are the alternatives? What are the other types of care models that we might be able to embrace on some level in order to try to basically try to reduce this burden of dental need out there. One thing that I am a believer in that might seem a little strange is that I think there should be clinics out there. There should be basically routes of getting dental care other than the traditional private practice setting. I worked in a health center for many years. I thought it was a very good educational experience for myself. I think it was great for the patients. It does not compete against private practice because it's different. You go there, you sit on folding chairs, and it's not the same as going to a private office. Even if the quality of care is excellent, even if the infection control, of course, that has to be excellent, et cetera, et cetera. However, it is different than going to a private practice. However, it's an alternative where if instead of ending up in an emergency room or in a hospital, it is preferable to basically go that route rather than neglect process. So there are ways we should really be thinking about this. You probably all also read in the papers or, in your classes about the idea of using, basically not personnel other than dental doctors, other than DMDs and DDSs to deliver dental care, dental therapists. Okay, that's very controversial. Okay, I think that's not my first choice, actually. I would rather see dentists working in other types of settings where treatment can be provided rather than a dental therapist. I think that would not be good, because if any of you have done surgery, have done restorative treatment, it takes a lot of skill. It takes a lot of training. It's not that easy. Okay. So I don't think dental therapist is a preferred option. Evidence-based dentistry is basically trying to condense down available information in order to answer clinical questions. Okay? Evidence-based dentistry doesn't really deal with that much laboratory studies or animal studies. It basically deals with focusing clinical evidence on obtaining answers to clinical questions. Okay, so if you wanted to know what was a better restoration for a molar, let's say a MOD, amalgam or composite, okay, laboratory studies can help you, but ultimately the answer has to come from a variety, an accumulation of clinical studies. So evidence-based dentistry is a method of really condensing together evidence derived from clinical studies. So what is called the evidence pyramid, okay? Clinical studies are high studies or publications which combine, which basically distill together a number of clinical studies, is the highest form of evidence. Things where doctors state their opinion are considered low types of evidence. Okay, so hard and fast axiom, dogma you've learned. Also, anecdotal evidence. Okay, you see an ad for a zirconium crown in the dental journal. Okay, you ask one of your professors and they said, oh, I did one once and it broke. Okay, that's important. That's valid. However, it would be better to know how 100,000 dentists managed with this. Okay, was there a higher incidence of this type of crown fracturing than a traditional ceramo-metal crown? So evidence-based dentistry is trying to pull together, apply an accumulation of clinical evidence to solving clinical problems. Okay, so to do evidence-based dentistry, you come up with a clinical question and you put it in a format where you get a evidence-based answer based on clinical studies. Okay, so meta-analysis is a method of combining clinical studies. Cochrane Review, the ADA evidence-based dentistry site is very good in terms of looking up clinical questions, and sometimes the answers are surprising. Sometimes even in caries prevention, does chlorhexidine, does xylitol prevent caries? It's sometimes not that easy to find convincing clinical evidence, even though in the laboratory it works, in small, well-controlled studies it works. Sometimes it's not that easy to really find the clinical evidence that supports something in as strong, in as robust a fashion as we would like. So so evidence-based dentistry is very important. I will be taking a big course in evidence-based dentistry. I just found out, in fact, in February at New York University, which is sponsored by the American Dental Association. So hopefully I'll get an opportunity to tell you all about it. Okay, so any questions, please, while we're still on the line here, please type them in, and I'll be happy to answer any. Okay. I'm sorry. There's one other question I don't. I only see, I'm informed, would you prefer that you not? Couple of questions here. One about sort of flossing adjuncts like water pick. I actually don't have a tremendous amount of experience with this. I would answer that the same way I would answer a question is baking soda toothpaste good for me? My answer to that would be if you like to use it and you think you're able to use it effectively, then it's good for you. Okay, I'm not aware really of. I know there are clinical studies with basically water expressing devices that that are supposed to clean teeth, sort of automatic flossers. However, if a person feels that they're able to essentially address areas of their teeth that they would not address with normal brushing and flossing, then it sounds like it works for them. Automated interproximal device, I would say the same thing. If basically a person feels that they're able to address areas of their dentition that they would not normally clean, then it is good for them. Okay. I'm sorry about that phone call. Okay, so I believe that there are no other questions. Let's see, we have a couple of announcements here to end the presentation. Thank you again for joining us. We're going to close with a quick survey, so please feel free to provide your feedback before you leave the session. And I thank you all for joining us this evening. And this is the 7th, so there is going to be, on your schedule, there is an 8th session schedule. So I thank you for your attention this evening, and I wish you all a good night. And if there are any questions that are emailed to me, if there are, I guess I could email people that send me questions, and I'd be happy to answer. Okay, thank you very much. Good evening. Bye.